Guys, very warm welcome to this free to access YouTube session on FMGE June 2022 session recall. So guys, here I am going to discuss all the 18 questions that had come in FMGE June 2022 session. So my focus will be to give you in a sort of a test and discussion format. So it will be very interesting, right? So before I start, so if you want to be the best, you have to do the things that other are not willing to do. Now you would say, sir, ये हमारे ऊपर कहाँ अप्लाई होता है? हम एग्जाम क्लियर करना चाहते हैं तो हम पढ़ तो रहे हैं ही हैं. गाइज, हेयर आई वांट टू टेल यू, एनाटमी, फिजियोलॉजी, बायोकेमिस्ट्री, पैथ, फार्मा किसी को भी पसंद नहीं होती है ना. मतलब बहुत वॉलाटाइल सब्जेक्ट्स है. सो वी ट्राई टू अवॉइड इट. हमें लगता है कि भाई हम थर्ड ईयर और फाइनल ईयर हम बार बार करते रहें तो ठीक है, बट नहीं. वी हैव टू फोकस इक्वली ऑन फर्स्ट एंड सेकेंड ईयर सब्जेक्ट्स. दीज सब्जेक्ट्स आर वेरी इंपॉर्टेंट. इनफैक्ट दीज सब्जेक्ट्स मेक द फाउंडेशन ऑफ योर MBBS. अगर ये इफ these subjects are removed from your MBBS curriculum, you would not be able to get your third and final year subjects because of the subconscious placement of first and second year subjects. You are going to perform well in your third and final year subjects. So my message to all of you is focus on all the subjects equally and try to rock every subject first. Second, I already know what giving up feels like. I want to see what happens if I don't. Don't give up. There will be conditions that would not favor you. There will be an environment that may not be favorable for your growth, but you have to keep holding on, and I am sure that you are going to, do wonders in your life. You are going to go at places, right? So to begin with, let's start up with the first question. So identify the given lesion. Now you would say, sir, blue light, green lesion, what is this? Guys, what happens is there is a dye which is sodium fluorescein dye. Whenever we suspect an epithelial defect, we stain the cornea with a sodium fluorescein dye, right? And when this sodium fluorescein dye is used for staining of the cornea, we examine the cornea in the cobalt blue light. So this fluorescein dye, which is taken up by the viable cells, so this dye will absorb the blue light and will emit the green light. As a result, it will outline the epithelial defect. And here, what do you see? This is known as dendrite. So so this dendrite is a feature of viral keratitis, but don't confuse dendrite with that of a pseudodendrite. So guys, in dendrite you have the knobbed ends, while in pseudodendrites you don't have a knobbed end, right? And dendrite is seen in typically herpes simplex virus keratitis, while pseudodendrites are seen in herpes zoster ophthalmicus. Now you would say, sir, both are herpes. What is the difference? My dear friends, herpes zoster ophthalmicus is actually varicella zoster virus. Acha, tell me one thing. In which other condition you could see pseudodendrites? Can you answer? Think about it. Very important. Acanthamoeba keratitis. In acanthamoeba keratitis, you can see pseudodendrites. Another important point about acanthamoeba keratitis, the symptoms are more than signs. Very important. Symptoms are more than signs here. Okay. So I was telling you about herpes simplex virus keratitis and herpes zoster ophthalmicus. So we have got dendrites, we have got pseudodendrites. So any viral keratitis, one characteristic feature will be loss of blink reflex, or you can say loss of corneal sensitivity. Now if you remember, so there is trigeminal nerve, which is a sensory nerve, then there is ophthalmic division of trigeminal nerve, then from ophthalmic division of trigeminal nerve there is a nasociliary nerve, and the nasociliary nerve gives branches to the tip and side of the nose, and it will give another branch which is known as long posterior ciliary nerve to the cornea, which acts as an afferent for the blink reflex. Now if there is viral invasion of the complete branch, ट्राइजेमिनल नर्व, गसेरियन गैंग्लियन, है ना, उसके बाद ऑफ्थैल्मिक डिवीजन, ऑफ कोर्स ऑफ्थैल्मिक डिवीजन ऑफ trigeminal nerve, then nasociliary nerve. So if there are lesions on the tip of the nose and on the side of the nose, corneal involvement will definitely be there. You call that as Hutchinson sign. So Hutchinson sign is seen in herpes zoster ophthalmicus, because if the virus has entered, if the virus has started to grow and proliferate into the nerve, of course it is going to go till the end na. So when there is involvement of the branch of nasociliary nerve, of course there will be involvement of the other branch of nasociliary nerve, which is long posterior ciliary nerve, right? So that is Hutchinson sign. So I have given you 4 or 5 important MCQs with regard to viral keratitis. Done. Chalo, what is the answer here? Of course viral keratitis. So this was the image that I showed while I was taking the session. Okay, now as I told you about the loss of corneal sensitivity, let's see. So this is our patient. Could you see that there are some lesions on the tip of the nose and side of the nose? Yes sir, very much prominent. So I'm taking the short history of the patient, so I'll quickly scroll through it. So here, yeah, see. So
अच्छा, और ये नाक पे भी आपके निकला हुआ है? बहुत ज़्यादा नाक पे, और आपको
so I'm asking her what is that thing on her nose. So she said there were vesicles which were on the nose and slightly on the inside of the nose. It was all around the right forehead and half part of the head. So she's explaining. So this is which condition? I repeat, this is Hutchinson sign seen in herpes zoster ophthalmicus. If I am suspecting herpes zoster ophthalmicus, of course when I am going to stain the eye of the patient with a fluorescein dye and I am going to examine it under cobalt blue filter, so what I am going to see? Dendrite or pseudodendrite? Quick, I am going to see a pseudodendrite. So let's.
और आपको लग रहा है आपकी नजर भी डाउन हुई है? हाँ जी, हाँ। सामने देखो.
So what I am doing is I am checking for corneal blink reflex. Check out the absent blink reflex. See, she's not blinking. She's not blinking. But please don't check blink reflex by holding the upper lid like this and then doing it. Of course, you are holding the lid upar na. So even if the patient's blink reflex is fine, you are going to appreciate as if there is no blink reflex. So don't do it like this, holding it and then putting the cotton. Simply ask the patient to look forward, come from the side and slightly touch the wisp of the cotton on the temporal part of the cornea. You can actually do it in all the 4 quadrants of the cornea: superiotemporal, inferotemporal, superinasal, inferonasal. But generally, grossly, you can take the cotton wisp and bring it to the temporal side of the cornea and slightly touch it. So you could very well appreciate in this patient that the corneal blink reflex is absent.
देखो, इधर देखो, सीधा.
Check this out. Absent. So viral keratitis.
सामने देखो.
Done? So now what I am going to do, I am going to stain her cornea with fluorescein dye. So this is Paracane, which is a topical anesthetic eye drop. So this is a fluorescein strip. So I am going to touch it. Touch it at the scleral region, inferior region. So you would see. Now slit lamp, cobalt blue filter. Now what could you see? This is a pseudodendrite. है ना? You cannot see knobbed ends ना. So this is a pseudodendrite. And cobalt blue light. है ना? Done? Understood? So I have given you a few important MCQs. Chalo, next question. So Kopi nodules are seen in. Guys, what are these Kopi nodules? So there is a condition known as anterior uveitis. And in anterior uveitis, there are nodules which could be Kopi or which could be Basaka nodules. And this is mostly seen in granulomatous uveitis. Very important. Granulomatous uveitis. And if I draw copenodules, so they are present at the inner margin of the iris. And if I talk about Basaka nodules, they are present at the base of the iris. So how will you remember B for? Can you see? It's big. It's present at base of iris. But copenodules are small. They are at pupillary margins. Pupillary margins. Right? So these are the nodules that are present on the iris, and hence the answer here. So here you can see, so Basaka nodules, copenodules. So here it is shown, these are small copenodules, and this is big, which is Basaka nodule, right? Anterior uveitis, please understand this. Okay, done. Chalo, आगे चलते हैं. So one thing I want to tell all of you is, which is the most diagnostic feature of anterior uveitis? Can anyone tell me? So what will it be? Will it be flare? Will it be keratic precipitates? Will it be hypopyon? Will it be iris nodules or something else? You would say, sir, आप कितने शातिर हो, जो आंसर है वो तो आपने बोला नहीं, हमने आपको पकड़ लिया. Yes, मैंने आंसर नहीं बोला. The most diagnostic sign of anterior uveitis is cells in the anterior chamber. Now, how you are going to appreciate the cells in the anterior chamber? You are going to throw a slit beam from one side, and in the dark region, so as you can see, so this is a slit beam. So this is the posterior surface of the cornea. This is the anterior surface of the cornea. And in between the posterior surface of the cornea and the iris, so this is iris. So this is what? This is anterior chamber. You are going to see the cells in the anterior chamber. So how you are going to see the cells? Try to appreciate the cells here. I am going to play a video. You may not see these cells too frequently, so you have to pay attention, right? Check this out. Check out the small white dots that you would see in the anterior chamber. Could you appreciate? Now see, could you appreciate? Small cells. Now see, I am able to see this. Are you able to see this? Check this out. Can you see these white dots? Can you see these white dots? Check these out. These white dots. You would see that these white cells, they are moving from inferior to superior. So these are cells in the anterior chamber, which is the diagnostic sign of anterior uveitis. If cells is not there, if cells option is not there, you can mark proteins in the anterior chamber, right? So don't go for, so there is a question which is doing rounds, which says most diagnostic sign of anterior uveitis. One is cells in the anterior chamber, second is flare in the anterior chamber, third is hypopyon, fourth is keratic precipitates. So in some books or at some places it is given as keratic precipitates, in some books or places it is given as flare. No, it is not flare, it is not keratic precipitates, it is cells in the anterior chamber, right? Chalo, आगे चलते हैं. So identify the image. So guys, can you see the dissymmetry? So this is one orbit, and this should be second orbit, but could you see this? What is this part? This is actually herniation of intra-orbital soft tissue. This is herniation of intra-orbital soft tissue. And why there will be herniation of intra-orbital soft tissue? In cases of blunt trauma, the inferior wall of the orbit would give way. When the inferior wall of the orbit would give way, so there will be herniation of the soft tissue, and as a result you will see a typical sign. This is known as teardrop sign seen on blunt trauma eye, leading to fracture of orbital floor or fracture of inferior wall. Is it understandable? Very important part, right? चलो आगे चलते हैं. So answer is orbital floor fracture. So this was the image that was shown to all of you guys. So another important point I want to tell you here is, what is the volume of orbit? Quick MCQs. This is 30 cc. What is the volume of eyeball? It is 6 cc. And please understand, the orbits are not facing forward. The eyeball is facing forward, but orbit is not facing forward. The orbits are divergent. So this is my medial wall and this is my lateral wall. My medial wall and lateral wall is not like this of right eye. It is like this. So there is some angle between the medial wall and the lateral wall. What is that angle? That angle is this, and it is 45 degree. This is medial wall, this is lateral wall. So it is like this. Done. Now what is the angle between two lateral walls? So this is my right orbit and this is my left orbit. If I want to know the angle between two lateral walls, guys, simple mathematics, it's 90 degree. Another MCQ. Now what is the shape of the orbit? Now you could see this is like this now. So this is apex and this is base. So it looks like a pyramid. So shape of the orbit is pyramidal with base anterior and the apex posterior. Very simple. Okay, understood. So the shape of the orbit is pyramidal and it has got four walls: superior wall, lateral wall, inferior wall, medial wall. Please don't forget to go through the bones which are forming the four walls. You should remember this. I always stress upon this in the class. Okay, so shape of the orbit, volume of the orbit, volume of eyeball. Acha, volume of eyeball is 6 cc. Do you know that vitreous humor forms 4 cc out of this 6 cc? Very important. So vitreous humor forms 4 cc. Okay, chalo, I have given you a few questions. Next is, a 60-year-old man is being treated with anti-glaucoma drug and his bronchial asthma got worsened. What could be the probable cause? So guys, you tell me, हमारे अंदर कितने हार्ट होते हैं? 1, 2, 3, 4. अब बोलोगे सर कई लोगों के तो 2, 2, 3, 3 होते हैं, बट उन्होंने ना बांटे होते हैं, ऐसा है ना. So we have got one heart, anatomically one heart, and hence B1, beta 1 receptors. We have got 2 lungs and hence B2, beta 2 receptors. So that means beta 1 is associated with heart and beta 2 is associated with lungs. Now we are talking of a drug that is contraindicated in bronchial asthma. So that means any drug that cause B2 blockade will precipitate bronchial asthma, because this B2 receptors are present on bronchi, and stimulation of these B2 receptors will cause bronchodilation. But if you will block these B2 receptors, so they will not lead to dilatation. But if the patient is asthmatic and you are giving B2 blocker, so it will lead to non-dilatation of the bronchus and it will precipitate the attack of asthma. So out of which is the drug that could lead to beta 2 blocker? Sir, beta blocker. Yes, the only beta blocker in the option is timolol, and it is non-selective beta blocker, which is it blocks both beta 1 and beta 2 receptors. Hence, it is contraindicated in asthma. But there is another drug which is selective. So we have got selective is beta 1 blocker. So that is not contraindicated in asthma, and the name of that drug is betaxolol. ठीक है? Okay, and what about brimonidine? Brimonidine is, I am writing it here, alpha 2 agonist. What about brinzolamide? It is carbonic anhydrase inhibitor. What is about latanoprost? It is PGF2 alpha analogs, prostaglandin analogs. Please remember, latanoprost is drug of choice in primary open angle glaucoma, in normotensive glaucoma, even it is given in primary angle closure glaucoma. Now, if the question asks, examiner asks, which was the drug of choice in primary angle closure glaucoma previously? So it was pilocarpine. Don't forget it. But now, the primary angle closure glaucoma, the drug which is preferred is prostaglandin analogs only, right? But earlier it was pilocarpine. And which was the drug of choice in primary open angle glaucoma previously? It was beta blockers. So, you know, with every passing year or decade, new researches come in and the drug of choice change. Done? Okay, now fine. So the answer we already know, it is timolol. So this is what I have explained. All right. Next question. A lady presents with grade 2 pterygium. What would be the best treatment in this case? Guys, first of all, please remember that pterygium treatment is medical or surgical or both. Guys, it is only surgical. There is no medical treatment in pterygium. So surgical is you simply excise the pterygium. You simply excise it. So one technique is bare sclera technique. You simply excise it. That's it. And leave the sclera as such. But the recurrence rate is up to 90% in bare sclera technique. So what you can do, so what was done is you take the conjunctival autograft from superiotemporal region and put it on this bare sclera on the nasal side. Now you would say, sir, why nasal side? Pterygium is on the nasal side or temporal side? My dear friends, pterygium is more common on the nasal side. It is more common on the nasal side. And what is pterygium? It is actually elastotic degeneration of conjunctiva. Elastotic degeneration of conjunctiva. And why it is on the nasal side? Guys, the most common etiology of pterygium is ultraviolet rays. So when the person is working hard in broad day sunlight, so the sun rays are going to fall on the bridge of the nose, and on falling on the bridge of the nose they are going to get deflected at the 90 degree. When they are going to get deflected at 90 degree, they are going to fall maximally on the nasal conjunctiva, and as a result the nasal conjunctiva will go into elastotic degeneration, not the temporal conjunctiva. That is why it is most commonly on nasal side. Why it is most commonly on nasal side? Because its major or main etiology is UV rays. Main etiology is UV rays, and UV rays fall maximally on the nasal side. Done. And this bare sclera technique, so you excise the pterygium and you take the conjunctival autograft from the superiotemporal region of the same eye and place it at the bare sclera. So you call that perfect surgery. Of course, that surgery is perfect because the recurrence rate is even less than 0.01%. So it is almost next to none. So these are few points. Another important point I want to give you in regards to pterygium is that pterygium extends upon the cornea. It will come upon the cornea and it will impinge up to anterior stroma. It has the ability to impinge up to anterior stroma of the cornea. Okay? So that is why it is very important to excise it. What if it is not excised on time and it comes to lie upon the pupillary axis or visual axis? Of course, the patient will develop difficulty in vision. Even after excision, there will be some remnant scarring which will be left. And if there is some remnant scarring which is in the pupillary axis or central cornea, of course, it will make the patient very, very irritated because the patient will not be able to see clearly. So it is very important to excise the conjunctiva on time once it is impinging upon the cornea. Done? Okay. So this is the surgical video that I had shown, and perfect surgery, it is pterygium extended resection followed by extended conjunctival transplant. Perfect surgery. So perfect surgery has a meaning. It is not like if the recurrence rate is less, so I said perfect surgery. So it actually has a full form. Okay, great. Now moving on to the next question. A child with poor socioeconomic background presents with white foamy spots in both the eyes. What could be the reason? Guys, white foamy spots, clear cut answer, vitamin A deficiency seen in conjunctival xerosis. So vitamin A deficiency, conjunctival xerosis. Please understand these foamy spots, these are bilateral mostly and they are on the temporal conjunctiva. They are on the temporal conjunctiva. Now this was the case that I had shown in the class, and yeah, the answer is clear cut, which is conjunctival xerosis. Bitot spots we are talking of here. Okay, chalo next. A patient presents with symptoms of floaters, flashes of light and then a curtain like shadow in front of the eye. What could be the probable diagnosis? Guys, clear cut. Flashes of light. What do you understand by flashes of light? You know what is retinal detachment. It is the separation of neurosensory layer and retinal pigment epithelium. Now if we count the layers from vitreous side, from inside, that is inner limiting membrane, the nerve fiber layer and so on, then the 9 layers, you call it as inner 9 layers, they are collectively known as neurosensory layer. Outer 10th layer, which is retinal pigment epithelium. So if there is separation between neurosensory layer and retinal pigment epithelium, so you call it as retinal detachment. And what happens, you know that there is some resting membrane potential of rods and cones. When there is retinal detachment, there will be sudden depolarization of the rods and cones. As a result, there will be discharges and it will be felt like flashes of light by the patient. Number 1. Second is floaters. Now what happens is, when there is separation of neurosensory layer with that of retinal pigment epithelium, the retinal pigment epithelium pigment will be spilled into the vitreous humor. When it will be spilled into the vitreous humor, it will appear as small pigment drops in the vitreous humor, and when the light will pass through the vitreous humor, these small pigment drops will cast a shadow on the retina, on the viable retina, and the patient will be seeing floaters. So what are floaters? Floaters are nothing but the shadows, है ना? So this is due to pigment in vitreous cavity, and this spilling of the pigment in the vitreous cavity, you call it as which sign? Schaeffer sign. Schaeffer sign. Done. Another MCQ cracked. Okay. And then lastly, a curtain like shadow in front of the eye. So what is happening? The typical history that the patient is going to give you, मुझे ऐसा लगा मेरी आंख के सामने पर्दा आ गया. I felt as if a curtain came in front of the eye, because of course if there is sudden retinal detachment of a particular area, the visual acuity of that particular area will be lost there and then. Part of the retina will be viable, but part of the retina will become non-viable because there is detachment. So the typical history that the patient is going to tell you is that he felt as if a curtain came in front of his eyes suddenly. So the answer is clear cut, which is retinal detachment. But if we are discussing retinal detachment, it is very important to discuss 2-3 more points. So retinal detachment can be of mainly 3 types. One is rhigmatogenous retinal detachment. Rhigmatogenous. Second is, I'm writing here, I'm rubbing it and writing here. Second is exudative retinal detachment. Exudative retinal detachment. Third is tractional retinal detachment. Tractional retinal detachment. Now rhigmatogenous, rhigma means break, and the retinal detachment which is due to break in the retina, you call it as rhigmatogenous. What is the etiology? If we are talking of break, trauma, aphakia and high myopia. Trauma, aphakia, high myopia. Exudative, what are the causes of exudative? Malignant melanoma of choroid, malignant melanoma of choroid, gestational hypertension. Few points I am giving you. Gestational hypertension, malignant hypertension, Coats disease, then VKH syndrome, and then CSR. CSR is central serous retinopathy. Important points regarding exudative retinal detachment. And if we talk about tractional retinal detachment, any cause that leads to neovascularization of the retina. So most common is diabetic mellitus, CRVO, sickle cell anemia, ocular ischemic disease, retinopathy of prematurity. So these are the causes of tractional retinal detachment. Just few points, hai na? Okay. And one last thing, rhigmatogenous retinal detachment, most commonly it is a horseshoe shaped tear. Horseshoe shaped tear, and it is commonly present as superotemporal aspect of retina. So it will be on the superotemporal side, and horseshoe shaped tear. Horseshoe shape mane like this. Is it understandable? Chalo, the answer was retinal detachment. We have already discussed. Okay. A child is being considered for IOL implantation. What should be kept in mind in such a case while choosing IOL power? Now guys, please remember that the axial length of eye at birth is approximately 16 mm, and adult axial length is 24 mm. Now if the child has got cataract and you are planning for cataract surgery with PCIOL implantation, of course you will go for which technique? Biometry. Biometry has got two components. One is A scan, by which you measure axial length. Another is keratometry. है ना? Now what happens is the biometry is going to calculate the IOL power with respect to the current axial length na. So if this is the eye of the patient, है ना, and you have done biometry, so the IOL which is implanted, so the image will be projected on the retina with respect to the biometry. You have implanted the IOL, but as a result of growth and development, the eyeball will grow and this retina will come to lie here now, because the axial length is increased, because it has to go from 16 to 24 na. So the axial length has increased. Now what will happen? If you had not done any correction, the IOL that you had planted, so it will be focusing the light rays at the same place. So as a result, as the growth and development of the eye will take place, the patient will go into myopia because the image is being projected in front of the retina. Understood? So what can you do to prevent this phenomenon? So you can go for correction. Now you say, sir, what is correction? Simple. If the age of the child is 0 to 2 years, you go for 20% correction, and age of the child is 2 to 10 years, you go for 10% correction. That means if by biometry the IOL power had come out to be plus 20 diopter and age of the child is say 1 year, you will go for 20% correction. You will deduct what? You will deduct 20% of the IOL power. So you will implant the IOL of the power plus 16 diopter. And here, if you are planning for 20D via biometry and age of the child is say 5 years, 6 years, 7 years, so you are going to implant plus 18 diopter of the IOL. So this is the correction that you have done, so that after some time when the eyeball will grow, so the focus of the light rays will be on the retina. Right? So this is what you can do. You can apply correction up to the age of 10 years. After 10 years, no need to apply correction. You just implant the power of the IOL that you have attained via biometry. Done? चलो आगे चलते हैं. अब A scan is axial length. What is keratometry? It is measuring of the curvature of cornea. Curvature of cornea. So it measures the horizontal and vertical curvature of cornea, and it takes the average of horizontal and vertical curvature. And which formula is used? Which formula is used? Remember something. So the formula which is used is Srk formula. The Srk formula is used to calculate the IOL power. But if the length of the eyeball is more than average, than usual, so you can use Srk T formula for long axial lengths. But if the axial length is smaller than usual, then you can use Hofer Q formula. So this was your previous AIIMS question, right? Okay, so let's move forward. So again, you know the answer. Myopic, this is what I have explained. Okay, a 3-year-old boy presents with itching and red eyes, which is more in summer. There is also ropey discharge from the eyes. What is the possible diagnosis? So we have to find the keywords. Boy is there, itching red eyes, more in summer, and a 3-year-old, and there is ropey discharge, typically depicting a condition which is allergic conjunctivitis, and that allergic conjunctivitis is VKC, which is vernal keratoconjunctivitis. But this vernal keratoconjunctivitis is more in summers, but the name of this vernal keratoconjunctivitis is spring catarrh. You would say, sir, spring catarrh? You just said that it is more in summer, so it should be summer catarrh. No, yes, it should be summer catarrh, but unfortunately this word is a misnomer. So this is a spring catarrh. So there is a ropey discharge. You call it as Maxwell-Lyon sign. So there is this discharge, very stingy ropey discharge, which consists of eosinophils. And next question is, it is more common in males. Very important. More common in males which are teenagers. Although in this question the examiner has mentioned the age of the boy as 3 years, but it is more common in teenagers, more common in summers, and it is a bilateral condition. I am giving you the important points on which MCQs have been asked. Bilateral condition, and this is type 1 hypersensitivity reaction plus type 4 hypersensitivity reaction. If this is not in the option, you will mark type 1 hypersensitivity reaction. If this is also not in the option, then you will mark type 4. Is it understood? So this is your first preference, second preference, third preference. And there is typical papillae that is seen on the conjunctiva, and that papillae is known as cobblestone papillae. Cobblestone. So they are arranged in the form of cobblestones like this. As you can see, cobbles at the seashores. Cobblestone papillae. Typically cobblestone papillae. Right? So this was a very important, discussion in regards to vernal keratoconjunctivitis. And let's move further. So this is spring catarrh. The answer we have already done, and this was also done in the class. So Maxwell-Lyon sign I have mentioned. So drug of choice will be olopatidine, sodium chromoglycate, and the ulcer which is associated with VKC is known as shield ulcer. So it is generally associated with all forms of allergic conjunctivitis, shield ulcer. And pseudogerontoxin is known as Cupid's bow outline. So you would say sir pseudo तो क्यूपिड्स वो आउटलाइन. सर जेरोंटॉक्सॉन क्या होता है? पहले जेरोंटॉक्सॉन बताओ फिर स्यूडो बताओ ना. जेरोंटॉक्सॉन इज द अदर नेम ऑफ आर्कस सिनाइलिस. सो आर्कस सिनाइलिस इज पेरिफेरल कॉर्नियल ओपेसिटी दैट इज एसोसिएटेड विद एज. इट इज ड्यू टू लिपिड डिपोजिशन एट द पेरिफेरल कॉर्निया. बट इन दिस VKC there is the peripheral corneal opacity that looks like arcus senilis, so hence the name pseudogerontoxin. So have you understood? Arcus senilis is gerontoxin. Pseudogerontoxin, the cornea, there is small peripheral corneal opacity. It looks like arcus senilis, but it is not arcus senilis, hence the name pseudogerontoxin. Done? Okay. A girl uses the contact lens shared by another person and develops painful red eye. What could be the most likely cause? Guys, one important point I want to tell you here is anyone using contact lenses and is having infection, the most common organism will be Pseudomonas. But if the examiner wants to know which is the most common infection associated with contact lens users who have a history of swimming in pond water, or who have washed their contact lenses with tap water, then it changes everything instantly. Then the answer will become Acanthamoeba keratitis. If we are talking of contact lens users who have a history of swimming in pond water and washing the contact lenses with tap water, that is why we said never wash your contact lenses with tap water. You can get Acanthamoeba keratitis and it is very painful. That is why we say that Acanthamoeba keratitis, the symptoms are more than signs. Normally we read na in fungal keratitis signs are more than symptoms. Here symptoms are more than signs, and I have already told you there is presence of pseudodendrite and there is a typical ring ulcer on the cornea. And another important thing, why there is so much of symptoms. If we are talking of symptoms, of course we are talking of pain na, because we are talking of keratitis. So symptoms will be more because of radial perineuritis. So there is perineuritis of the corneal subepithelial nerves. So that leads to intense pain. Although the corneal ulcer looks pretty decent, मतलब देख के ऐसा लगता है कि इतनी ज़्यादा condition खराब नहीं होगी. That is why we say that symptoms are more than signs. And the drug of choice that we generally give is PHMB, polyhexamethyl biguanide. So these are few 2, 3, 4 points about Acanthamoeba keratitis. But otherwise, if it is asked which is the most common infection associated with contact lens users, you will go for Pseudomonas infection. And please, my dear contact lens users, please don't forget to change your solution every 2 days. right? Don't think that, I haven't used contact lenses, so that's okay, I can keep my contact lenses soaked in that solution for like 5-6 days and then use it. It's absolutely okay, and you may be using it and you may not be having any infection. You never know, you may have the infection immediately, right? Okay, so you need to take care, especially the contact lens users, you have to take care. Okay, chalo, now moving on to the next question. So before that, this is what I have told you. Done. चलो आगे. हाँ, या the following image shows the findings of a patient when retinoscopy done at a distance of 1 meter and under homatropine. Right now we know that a correction has to be made. If we are doing it from 1 meter, a correction of -1 is to be done, and if we are doing it from via homatropine, then -0.5 correction is to be done. So net correction which is to be done is -1.5. Right now the value that we got at x-axis was plus 3.5 and the value that we got at y-axis was plus 2.5, right? But the corrections we have to apply. Since we have to apply corrections now before prescribing spectacles, so plus 3.50 minus 1.5 because we have to apply correction, and plus 2.50 minus 1.50, so it will become plus 1.00 and it will become plus 2.00, right? And we are smart enough, what we can do is we can prescribe plus 1.00 spherical. So that means that spherical component will cover both at x-axis and y-axis. So y-axis is gone and x-axis plus 1 diopter has been compensated by this sphere. Now we are left with plus 1.00 diopter extra. So net will be plus 1.00 diopter, and here will be 0 because we have prescribed plus 1.00 diopter spherical. Now we have to give a correction specifically at x-axis. So we will give plus 1.00 diopter sphere plus 1.00 diopter cylindrical. At which axis? We want the power at x-axis, na? So because we want the power at x-axis, we will keep the cylinder at 90 degree because the cylinder will always act at the opposite axis. Why? Because if we are going to place the cylinder at 90 degree like this, the curvature of the cylinder is like this. So hence this is which axis? This is x-axis. So the cylinder will act, the erect cylinder will act at x-axis, and the lying cylinder or horizontal cylinder will act as at y-axis. Is it understandable? So the answer here would be plus 1 diopter sphere and plus 1 diopter cylinder at 90 degrees. So hence the answer is this. I hope you have understood this. So the answer is this. Let's take another example just for revision purposes. So on atropine, so I have changed it from homatropine to atropine, and at 1 meter atropine the correction done is 1 diopter. 1 meter is again 1 diopter. So net correction which is to be done is minus 2 diopter, and here it is minus 2.5, here it is minus 4.5. But guys, please understand, we will take care of the minus sign and the plus sign, right? So here what will be the effective value? Minus 2.5 will become minus 2. Here minus 4.5 will become minus 2 because minus 2 is the correction, na? So minus 2.5 will become minus 4.5 and minus 4.5 will become minus 6.5. As a result, we are smart enough, we'll give minus 4.5 diopter sphere. So that would make this y-axis 0 and would leave the remnant number at x-axis as minus 2.00. So we can give minus 4.5 diopter sphere and minus 2.00 diopter cylinder at 90 degree. So that was the point I was trying to make. Is it understandable? Okay, so I hope you have understood the concepts in retinoscopy. Okay, and if I do it from a distance of 66 centimeter, so I have decreased the distance, so the correction will become 1.5 diopter. So the nearer to the patient I am, the more correction I'll have to do. right? So sometimes it is mentioned instead of 1 meter, it is mentioned 2 by 3 meters, which is 66 centimeter, or directly it is mentioned 66 centimeter. Then the correction that you are going to do will be 1.5 for distance, and if it is homatropine, so 1.5 plus 5 it will become -2 diopter, and if it is atropine it will become -2.5 diopter. Is it understandable? Any doubts, you can message me, you can ping me on Instagram, Facebook Messenger, Telegram. I'll be there to help you there and then. Don't worry about it. Okay? Chalo. Next चलते हैं. An elderly man who is one-eyed got punched in his only seeing eye. He presents with painful decrease in vision. What could be the diagnosis? So if we start eliminating the options one by one, so conjunctival hemorrhage, subconj hemorrhage cannot lead to painful decrease in vision, number one, so it is removed. Sympathetic ophthalmitis is entirely a different entity. It is bilateral, granulomatous, non-suppurative panuveitis. Okay, now the answer could be either optic neuritis or retrobulbar neuritis. Now optic neuritis can present as painful, it can even present as painless, but retrobulbar neuritis, it will present as painful on ocular movements. Now you say, sir, why painful on ocular movements? ये क्या संबंध है? Guys, simply understand that the dura mater of the optic nerve is in continuation with the superior rectus muscle sheath. So when the patient with retrobulbar neuritis, you will ask the patient to elevate the eyeball, there will be stretch on the superior rectus muscle. As a result, there will be a simultaneous stretch on the dura of the optic nerve, and there will be pain on ocular movements. And in this question, they have not mentioned about the ocular movement. So we are taking that we can mark the optic neuritis since it is both presented as painful or painless. So the better option will be to mark optic neuritis here. So then probably the condition is TRON. TRON is traumatic optic neuritis, leading to traumatic optic neuropathy. Okay, is it understandable? So then you are going to pick optic neuritis. Is it understandable? So hence the answer here. So this is what I have explained about retrobulbar neuritis. Done? Okay. A child is brought by parents with white pupillary reflex. On examination, a cauliflower-like mass with calcification is seen growing from retina. What is the most likely diagnosis? Guys, simple, typical presentation. Pupillary reflex mane leukocoria. We'll go step by step. What are the DDs of leukocoria? Retinoblastoma, PHPV, Coats disease, congenital cataract, toxocariasis, retinopathy of prematurity, endophthalmitis, coloboma. These are differential diagnoses of leukocoria. But out of these, retinoblastoma presents with calcification. Very important. So, pupillary reflex, leukocoria, cauliflower-like mass with the calcification. So, the answer is retinoblastoma. Now, I want to give you a few points about retinoblastoma. Guys, the most common age at which it is presented is 18 months, number one. Number two, most common sign is leukocoria. If it is not given in the option, you can mark strabismus. Then, investigation of choice to detect metastasis is MRI. This is my own AIPG MEE question. Why MRI? Because it metastasizes via optic nerve, and optic nerve to MRI पे ही पता लगेगी. Now, as I told you that there is calcification in retinoblastoma. So, which is the best investigation to detect calcification? CT scan. Which is the first investigation? USG. You all know it. Simple questions. USG. Right? And which is the characteristic which is the characteristic histopath appearance in retinoblastoma. It is flexor Wintersteiner rosettes. Flexor Wintersteiner rosettes. Guys, I am writing it just for you so that you are able to take down the notes. I always say in my classes that you have to have handmade, self-made notes. Don't just go for के screenshots ले लिए, it's done. No, it is not going to help you. There is some memory known as muscle memory. I am talking to you and side by side I am writing because my muscles are primed for it. So there is some memory which is muscle memory. The more number of times you are going to take down the notes, the better you will be able to remember it. है ना? So these are small things that you need to learn, and it will only and only increase your efficiency in the real exam. Okay, चलो, so आगे चलते हैं. So the answer is retinoblastoma. Done. So again, stressing upon IOC to detect metastasis is MRI. Okay, a young boy suffered blunt trauma and develops monocular diplopia. What could be the reason? Guys, simple. Hyphema cannot lead to diplopia. Strabismus, it leads to binocular diplopia. That means if the patient is seeing with both the eyes, then there will be diplopia. If the patient will close one eye, there will be no more diplopia. You all know it, strabismus. What about cataract and iridodialysis? Now you need to understand. In cataract, what do you understand by cataract? Cataract is precipitation of insoluble proteins or hydration of fibers. Whenever there is precipitation of insoluble proteins, so there is increase in the refractive index over that area. As a result, there will be more bending of the light rays, and the focus will not be on the retina but at the different places on the retina, because so one ray is coming like this, but here due to the more bending the rays are falling here. Here due to more bending the rays are falling here. So there will not be only diplopia, there can also be polyopia if there are multiple focal points. Of course there can be diplopia as well, but there can be polyopia because of multiple focal points on the retina. Number one. What do you understand by iridodialysis? Iridodialysis is the separation of circular and longitudinal layer of the muscle of the iris. Now this is normal iris. Now what happens in iridodialysis is due to trauma, so there is separation of the iris root. So this is the iris root. So one pupil is this through which the light is passing and falling on the retina. Another pupil is this through which the light is passing and falling on the retina. So virtually there are two pupil, है ना? Because due to tearing up of the base of the iris, now there is one space through which the light can pass. So hence the patient will present as diplopia. But history says a young boy suffered blunt trauma and develops monocular diplopia. Now you can say, sir, why not cataract? Why only iridodialysis? Guys, for cataract it will take some time for the development of cataract, but the history says a young boy suffered blunt trauma and develops monocular diplopia. So if you'll read the history in one go, you will understand what the examiner wants to know. Examiner is saying that trauma happened and the patient presented with diplopia. That quickly cataract will not develop. It will take at least some time, maybe 6 or 7 weeks, maybe 4 or 5 months. It may take maybe 10-12 months or maybe 3-4 years for the development of the cataract. But it will not be sudden. On reading the sentence, it appears as if the trauma happened and the patient presented with diplopia. Okay, so the best option here is iridodialysis. Done. Chalo, आगे चलते हैं. So yes, this is what we have discussed. Now next is a patient suffers trauma with vegetative matter and presents with ulcer and hypopyon and satellite lesions. So guys, again typical history, vegetative matter sometimes maybe like आँख में मिट्टी चलेगी, गाय ने पूंछ मार दी. No, this actually happens. So sometimes the patient would come and would say, I was walking on the road, the cow wagged the tail and the hair on the tail, it touched my eyes. So there was some redness. I washed my eyes and I was all right. But after 10-15 days, I started to develop redness, photophobia, pain, and you would see that the cornea is full of fungus. This actually happens. So vegetative matter and presence with ulcer with hypopyon and satellite lesions. Typical history, it is fungal keratitis. Now few points about fungal keratitis. Guys, do you know that in fungal corneal ulcer, the ulcer is dry looking with fluffy margins. Very important, with fluffy margins, and hypopyon will be there. What is hypopyon? It is pus in the anterior chamber. Now this hypopyon will be fixed and non-sterile. Non-sterile means it will be having fungus in it. The only organism that has the ability to penetrate intact cornea is fungus. Mind you, I am not saying ability to penetrate intact corneal epithelium. Then we have got Listeria, Haemophilus, Corynebacterium diphtheria, and many other organisms. But I am talking of intact cornea. The only organism, it is fungus. And why it is fixed? So guys, you must have heard we should plant more trees. It prevents floods. Why? Because the roots of the trees will hold the soil together and will not allow to move it in case of floods. है ना, यही होता है ना. Similarly, the fungus has entered into the anterior chamber and the roots of the fungus, you call it as hyphae of the fungus, is holding the hypopyon at its place and would not allow hypopyon to move. As a result, it will be gravity non-dependent, or you will call it as fixed. Is it understandable? And what are the satellite lesions? Moon is the satellite of Earth. Moon keeps on rotating around the Earth. So satellite lesions are small lesions around the main lesion. So you call it as satellite lesions. So this is fungal keratitis or mycotic keratitis. Very important. Done? Okay. And signs are more than symptoms. Which disease has symptoms more than signs? Quickly, are you active? Are you carefully listening to what I have been saying? Then you should answer it. That is acanthamoeba. So in acanthamoeba, the symptoms are more than signs because there is more pain. There is radial perineuritis. Got it? Good. चलो आगे चलते हैं. So yes, fungal keratitis. Next is patient has distress on reading on examination. There is no problem of short-sightedness or long-sightedness, but Shermer test reading is 5 mm. Achha. What is the treatment in this case? Guys, what I realized, what I have seen in COVID times now, that there was increased screen time of almost everyone. People got addicted to mobile phones. They got addicted to OTT platforms, tabs, pads, and whatnot. And do you know what is the normal blinking frequency? A normal human blinks once every 7 seconds. And when you are too much indulged into watching a movie on a screen or maybe on a pad or maybe on a tab, then the blinking frequency becomes once in 25 seconds. And what about that 10 seconds, 7 to 10 seconds to 25 seconds? During this time, the cornea remains dry. And as a result, when you blink at that time, so there is complete burning sensation in the eyes. Why is it there? Imagine you want to wash the windshield of a car. So you pull the arm forward. So there will be first shower, then the wipers will move, right? The wipers will move and as a result, the screen will be washed. Imagine there is no shower, just the dust getting collected on the windscreen. And when you will pull the arm forward and the wipers will move without shower, so what is going to happen? It is going to rub upon the windscreen, and as a result it may even lead to development of small microscopic scratches on the screen. This happens now. Similar is with our eyes. If the patient is having dry eyes and the lids are blinking, है ना, and lids act as wipers, as a result the patient can develop micro scratches on the cornea, and that could lead to pain, discomfort, photophobia, and very much difficulty and a burning sensation. So this, in that case, what you are going to do? You are going to put a shower on the cornea, like you put shower on the windscreen. So that shower is actually lubricants. And also Shermer test reading is 5 mm, which tells you that it is a severe dry eye, right? So the treatment in this case will be lubricants. I hope you have understood this. Okay, great. चलो आगे. Next is patient presents with hard painless nodule growing externally away from lid margin. What is the most likely cause? So growing away from the lid margin, the answer is chalazion. Chalazion is lipogranulomatous inflammation of which gland? जल्दी बताओ जल्दी. तुम लोग बता नहीं रहे, लगता है टाइम पास कर रहे हो. ऐसे नहीं चलेगा. लाइपोग्रेनुलोमेटस इन्फ्लेमेशन ऑफ मिबोमियन ग्लैंड. Meibomian gland. But why this inflammation is happening? Because of blockade of the duct. Blockade of duct of Meibomian gland. Right? Now what is external hordeolum? External hordeolum is tie. It is more commonly seen at hair follicles. If hair follicle is not in the option, then you are going to mark gland of Zeiss. Done. What is internal hordeolum? It is infection of, don't confuse internal hordeolum with chalazion. This is infection of Meibomian gland. ठीक है जी. So one is infection, one is blockade of the duct of Meibomian gland. Done. Another important point I want to tell you here is what is the treatment of chalazion? It is I and D. You incise and drain. Now the next question is, how do you incise? If you are removing chalazion from the inner side by everting the upper eyelid, you will give vertical incision. Vertical incision if you are incising it from inside. Now if you are giving an incision from outside, you want to drain the chalazion from outside, you will give a horizontal incision. So outside means superficial part of the eyelid, so you will give horizontal incision. Now you would say, sir, why is it so? Because if you will not give a vertical incision while incising and draining the chalazion, if you are going to give horizontal incision, you may cut the around lying Meibomian gland ducts, and nobody would want that to happen. So you give a vertical incision while giving IND by everting the eyelid. Done. Okay, so these were few points about chalazion, and it is a painless swelling, and this is how it is done. See, I have everted it with the help of chalazion clamp, and this is chalazion scoop. So you scoop out the lipogranulomatous inflammatory substance. So the answer is simple, chalazion. So this was the surgery that I had shown during the class. Okay. Next is patient presents with bilateral ptosis, which is variable during the day and reduces on putting the ice packs. What is the most likely diagnosis? Guys, simple. What is myasthenia gravis? So myasthenia gravis is an autoimmune condition in which antibodies are formed against acetylcholine receptors which are present on post synaptic junction. इतना समझ में आया? They are present on post synaptic junction. Now what happens is, from presynaptic junction acetylcholine is released. Now this acetylcholine settles on the acetylcholine receptors on the post synaptic junction and cause the muscle contraction. That's it. Now what the examiner is asking is, you know that in myasthenia gravis, because there is decrease in the number of acetylcholine receptors, so there is decrease in the activity of the muscle. As a result, the muscle will not able to contract that frequently. As a result, there will be drooping of the upper eyelid, which you call it as ptosis. So there will be bilateral drooping of the upper eyelid. But what happens is, if you are going to place ice packs on the eyelids, the drooping would improve. It would not deteriorate, it would improve. How? Because you know, whenever there is acetylcholine which is released into the synaptic junction, it will sit on the acetylcholine receptors, but there is another enzyme which is known as acetylcholine esterase. Now this acetylcholine esterase, this degrades the acetylcholine, है ना? Now this degraded acetylcholine will be taken back into the presynaptic junction, and when you are applying cold packs, so that cold pack is actually not allowing acetylcholine esterase to function. It is inactivating the acetylcholine esterase. As a result, the acetylcholine esterase will not be able to degrade acetylcholine. As a result, the acetylcholine will be able to stay into the synaptic junction for the longer duration of time. As a result, it will prolong its action. As a result, the condition of drooping of the eyelids will improve. Have you understood? नहीं समझ में आया? बैक करके दोबारा देख लेना, सुन लेना. So the answer is clear cut, which is myasthenia gravis. In short, putting the ice packs will inactivate the acetylcholine esterase enzyme that would not be able to degrade the acetylcholine, and as a result it will prolong the action of acetylcholine, which is contraction. So there will be reduction of the ptosis in myasthenia gravis on putting the ice packs. Done? Chalo. Now next is we are done with our session. So while signing out, I'm going to give you two quotes. One is, nothing is particularly hard if you break it down into small jobs. So baby steps every day will make you go to the places that you never had imagined. Trust me on that. ये नहीं कि आज पढ़ने लगे तो 8 घंटे पढ़ लिया, you are feeling immediately motivated, you read for 8 hours and then you didn't read for next 5-6 days. No, this should not happen. You read, if you don't want to read for prolonged duration of time, just keep reading, by small amounts, and at the end of a month or maybe at the end of 3 or 4 months, you would yourself be surprised by your performance. So that is what I wanted to say here, and this is something sarcastic. Kill them with success and bury them with a smile. Have you understood? समझने वाले समझ गए है ना? So with this I would like to sign out, and any queries, any doubts, you can always message me, text me on Facebook inbox and Insta, Telegram. So आजकल तो digitalization का ज़माना है, so we are available. You can, any academic, non-academic queries, you can always get in touch with any of us. We are always here for you. And in the end, I would like to thank you for your presence, for your patience, for patiently listening to me. And I felt as if I am sitting amongst yourselves and we are having a healthy discussion over the topics. And I thoroughly enjoyed this session. And how did you like the session? Do let me know. And best wishes from my side. God bless. Bye-bye. Take care. Thank you.